Welcome back to the deep dive. Today, we're really getting into something critical for anyone in caregiving,
Absolutely. It's a vital topic.
end-of-life care, specifically in geriatric nursing. And we're drawing from, Chapter 15 of Basic Geriatric Nursing.
Yeah, and it's so important because, well, how we experience death now is just, it's completely different than it used to be.
Different how? What's changed?
Well, think back a few centuries. Death was much more common in daily life, more familiar, often happened at home.
Right, part of the community experience.
Exactly. But now, with modern medicine, it's often linked to advanced old age, chronic illness, and it happens mostly in hospitals or care facilities, overwhelmingly so.
The numbers really show that, don't they? Something like, what, over 73% of deaths are people over 65.
That's right. So our focus today, our mission, if you like, is to really unpack the core ideas for giving care that's effective, but also truly compassionate.
Okay. So we need to look at the legal side, how we communicate, the actual physical changes.
And the philosophy behind terms like palliative care and hospice too, #tag, patient autonomy and end-of-life planning.
All right, so where do we start? Patient autonomy seems huge in modern healthcare.
It is. And, modern Western culture really emphasizes individualism. That makes end-of-life decisions pretty complex, often very legalistic.
Lots of forms, lots of procedures.
Yeah, and it can bring up ethical challenges. But one interesting thing the chapter points out is that older adults, they're often much more open to talking about this stuff.
Really, more than younger people.
Often, yes. They've usually experienced loss, parents, maybe a spouse, friends, and that experience tends to give them, well, a certain clarity about what they want or definitely what they don't want.
So planning ahead isn't just a nice to have, it's essential. And it has to happen before things get critical.
Absolutely critical. We're talking about advanced directives, things like POLST forms, living wills, documents that clearly state what kind of medical interventions the person wants or doesn't want.
And these aren't just papers you file away, right?
No. They need discussion, real understanding. They need to be shared with the whole care team, with the family. Everyone needs to be on the same page.
And for the patient to even make that choice, they need to be properly informed. What does informed really mean in this context?
It means understanding the trade-offs. Radical transparency. The textbook lists about 7 key points, but you can boil it down.
Trade-offs. Okay, give us an example.
So instead of just saying, here are options A, B, and C, the conversation has to be about quality versus quantity of life. Like, okay, this treatment might give you, say, 6 more weeks.
Right.
But, those weeks might involve significant pain. You'll need round-the-clock care. It could drain your savings. It's about the likely quality of life, the pain involved, the time needed, costs, alternatives, all of it.
That really changes the role of the healthcare professional, doesn't it?
Completely. The QSEN standards reflect this shift to patient-centered care.
Yeah.
We're not the authority figures telling people what's best anymore.
We're more like service providers, facilitators.
Yeah. Exactly. Facilitating the patient's own informed choice. And honestly, that could be a tough mental shift for caregivers.
How so?
We're trained to fight death, right? To see it as a failure, a professional failure.
Mm-hmm.
So to be truly patient-centered, we have to look inward. The chapter mentions a value clarification exercise. We need to understand our own feelings about death so we don't unconsciously push them onto the patient.
Because ultimately the goal is what the chapter calls a good death. What does that look like?
Well, the wishes seem pretty universal when you ask patients. They want dignity, respect, they want to know what's happening, what to expect.
Control.
Yes, control over decisions, over symptoms like pain, and crucially, time. Time to say goodbye, to connect on their own terms.
Okay, that seems like a good point to define 2 key terms. Palliative care and hospice, they get mixed up sometimes.
They do. So palliative care, think of it as focused on improving quality of life. It's about reducing suffering, pain, nausea, shortness of breath, anxiety for anyone with a serious illness. Doesn't matter what the prognosis is.
So you can get palliative care even while you're still getting treatment meant to cure you.
Yes, exactly.
Yeah.
It affirms life, accepts death as normal eventually, but focuses on optimizing the life the person has now.
And hospice, how is that different?
Hospice is more of a philosophy, really, a philosophy of compassionate, supportive care when curative treatment is no longer the goal or is stopped. Usually the prognosis is about 6 months or less.
And it's not always a specific place, right?
Right. It can be provided at home, in a nursing facility, sometimes in a dedicated hospice unit. But the tragedy the chapter highlights is timing.
Timing.
Yeah. Most people Something like 80% say they want to die at home. But where do most deaths happen? Hospitals, about 60%, or long-term care facilities, maybe 25%.
Wow, that's a huge gap.
It is. And even worse, over 40% of patients who do enroll in hospice, they enroll really late, like less than 14 days before they die.
Less than 2 weeks. Why does that matter so much? What are they missing?
They're missing the full benefit. Hospice offers comprehensive support, not just medical, but psychosocial, spiritual support for the patient and the family, specialized symptom management.
Okay.
If you only get in 2 weeks before the end, you're often just getting crisis management. You miss out on that period of potentially higher quality living that hospice is really designed to provide.
Why the delay then?
Often it's complex, maybe physician reluctance to give up hope, sometimes family denial, maybe lack of awareness about what hospice truly offers. #2, cites hazy cultural and spiritual considerations.
Okay, so we've covered the planning and the definitions. But end-of-life decisions are rarely made in a vacuum. Culture plays a massive role, doesn't it?
Oh, absolutely, profoundly. Cultural beliefs shape everything. How we talk about death, who makes the decisions, what treatments are seen as acceptable, even how pain is interpreted or expressed.
Communication seems like a key area where cultures differ.
Definitely. Take the Western idea of the patient's right to know. We generally believe patients should be told their diagnosis and prognosis directly.
Right, full disclosure.
But in many other cultures, the text mentions some Asian American, African American, Mexican American groups as examples talking directly about impending death can be seen as incredibly insensitive, even harmful. It might be something the family manages.
So as a nurse, you can't just walk in and state the facts. How do you navigate that?
You have to ask, neutrally, something like, some people prefer I share health information directly with them, while others prefer I speak with a designated family member. What is your preference?
And language barriers.
Always use a professional medical translator. Never rely on family members. They're too emotionally involved, and accuracy is paramount.
That difference also shows up in who makes the decisions, right? Individual versus family.
Exactly. The Western focus is heavily on individual autonomy, hence the emphasis on advanced directives signed by the patient. But many non-Western cultures see these major life and death choices as family matters, a group decision.
Which might explain why ADs are less common in some groups.
It's a contributing factor, certainly.
So here's a tricky scenario. What if a nurse is trained to aggressively treat pain almost as a default? But the patient's cultural or spiritual belief is that suffering has meaning. Maybe it's a test of faith or preparation for the afterlife, something not to be automatically eliminated.
That's a core conflict we often face. The absolute priority has to be understanding and respecting the patient's value system.
So ask first, treat second.
Always. Some individuals or groups might want every possible intervention to prolong life. Others might see pain differently. Our job is to assess their goals, their definition of comfort, and work with them to achieve that, not impose our own definition.
Which leads us naturally into spiritual care. QSEN standards highlight this too.
Yes, and spirituality often becomes more prominent as someone approaches the end of life.
The
The nurse's role here isn't about religion necessarily or pushing beliefs.
It's about support.
It's about support, active listening, respect, assessing their beliefs, asking if they'd like to speak with a spiritual counselor, a priest, a rabbi, an imam, whoever is appropriate for them.
And practical things too.
Absolutely. Accommodating practices. Like, if prayer requires facing a certain direction, help move the furniture if needed. Be present. Listen without judgment. Never impose your own views. #tag3. Physiological changes and nursing interventions.
Okay, let's shift gears to the more clinical side. The physiological changes as death approaches. We can't predict the exact moment, but there are signs, right?
Yes, there's usually a pattern. Increased sleepiness, being less responsive, sometimes confusion or seeing or hearing things, maybe loved ones who've passed. People tend to withdraw socially, and breathing patterns change.
But the number one concern, the biggest fear for most people dying, is pain.
Without a doubt, pain management is priority number one, and the goal is specific. Reduce pain to a level the patient finds acceptable, while hopefully keeping them alert enough to interact.
Still comes back to the patient's definition.
Always. Pain is what the patient says it is. That's the golden rule. And we have to remember, older adults often underreport pain.
So you need good assessment skills. What are you looking for beyond what they say?
Nonverbal cues are key. Restlessness, agitation, moaning, groaning, maybe guarding a part of their body. Even subtle things like facial expressions. Simple pain logs, maybe kept by the family, can be really helpful too.
And interventions. What's the approach?
The approach is Don't give up. Be persistent in finding what works. Often it's a combination, maybe long-acting opioids for constant pain, with short-acting ones for breakthrough pain.
Different ways to give the meds, too.
Yes, various routes, oral, patches, subcutaneous. One crucial point: never crush sustained-release pills that can cause a dangerous overdose, and always combine meds with non-drug approaches. Massage, relaxation, music, maybe even virtual reality now. Simple comfort measures.
The chapter also mentions palliative sedation for really extreme suffering. That sounds ethically complex.
It is, and it requires careful discussion. The absolute key point to make clear to families is the intent. Palliative sedation is used only to relieve unbearable suffering that hasn't responded to other treatments.
It's not euthanasia.
Absolutely not. The intent is not to hasten death. It's to provide comfort during the dying process. That distinction is vital.
Okay. What about other systems? Cardiovascular changes.
Circulation slows down, especially to the hands and feet. Skin might look pale, maybe bluish, feel cool. Blood pressure naturally drops. Body temperature might fluctuate.
So comfort measures are key here too.
Simple things. Adjust the room temp. Offer bed socks, maybe an extra blanket. Warmed blankets feel nice, but absolutely no electric blankets. Risk of burns is too high with fragile skin and poor circulation.
And breathing, what happens there?
Respiratory issues are common. Dyspnea, that feeling of shortness of breath, is very common. It's subjective, remember. It might not match their oxygen saturation levels.
So just putting on oxygen might not fix the feeling of breathlessness.
Correct. Sometimes simple things work best. Changing position, elevating the head of the bed, using a fan to circulate air, reducing anxiety.
And that distinctive breathing pattern.
Ugh. Cheyne-Stokes respirations. Periods of faster, deeper breathing alternating with periods of apnea, no breathing. It can be distressing for families to watch. For severe dyspnea, low-dose morphine is often very effective.
Morphine for breathing.
Yes, it reduces the air hunger sensation. But the team needs to be ready to explain to the family that, yes, a therapeutic dose might also make the patient drowsy. It's part of managing the symptom effectively.
All right, let's talk about the gut. GI changes. This seems like an area that causes families a lot of distress. The loss of appetite, anorexia, and the muscle wasting cachexia.
It really does. It hits a primal instinct, doesn't it? Wanting to feed someone you love when they're fading.
Yeah.
Probably the hardest thing to explain is that this loss of appetite is often a natural part of the dying process. It's physiology, not neglect. We encourage focusing on pleasure, small amounts of favorite foods, good mouth care, but never, ever force feeding.
Which brings up artificial feeding and hydration, tubes and IVs. What does the evidence say near the end of life?
The evidence suggests the benefits are often very limited, and the risks can be significant. Aspiration pneumonia, infections, fluid overload. It can actually become more of a burden than a help.
So forcing fluids or nutrition might not actually improve comfort or extend life meaningfully?
Frequently, no. And interestingly, some research suggests dehydration near death might even have benefits, potentially releasing endorphins that reduce pain and lessening lung congestion, which can make breathing easier.
That's counterintuitive and important.
It is, and related to that is xerostomia, just really dry mouth, very common. Simple fixes help: humidifiers, frequent mouth swabs with water, or special solutions, not alcohol-based. Lip balm that isn't petroleum-based.
And constipation, also common.
Very common, especially with pain meds like opioids and decreased mobility and intake. Prevention is key. Fluids, if they can take them, fiber, stool softeners, maybe laxatives. Just need to be very cautious with things like manual disimpaction if the patient has low platelets, thrombocytopenia, because of bleeding risk.
Okay, last area here. Senses and thinking. What changes?
Vision often narrows, like tunnel vision. So indirect lighting is usually more comfortable than bright overhead lights. But the absolutely critical takeaway here for everyone at the bedside:
Let me guess.
hearing. Hearing remains acute until the very end. Assume the person hears everything said in the room, even if they seem completely unresponsive.
Wow, that's powerful.
It means speaking calmly, respectfully, explaining what you're doing, and crucially, avoiding negative or upsetting conversations anywhere near them. We also see delirium, sometimes sudden confusion. It's important to check for treatable causes like low blood pressure or metabolic problems. #tag for CBA joy, death, postmortem care, and bereavement.
So when the actual moment of death arrives, what are the definitive signs?
Clinically, it's the absence of a heartbeat and breathing. No response. The eyes might remain open slightly, but there's no blink reflex. Pupils become fixed. They don't react to light. A physician legally pronounces the death.
And the nurse's role with the family right at that moment.
It's about support and sensitivity. Ideally, you've already talked about their wishes, who should be called, if they want to be present.
Right, that earlier planning.
Exactly. After the pronouncement, give the family space. Quietly turn off monitors, remove IV lines or tubes if appropriate. Just allow them private time to begin processing, to grieve, before you start post-mortem care. Offer simple words of sympathy.
And the care of the body afterwards, post-mortem care.
This absolutely must respect the patient's cultural and spiritual preferences. Always ask the family. Standard care usually involves gently closing the eyes, maybe using a rolled towel under the chin to help keep the mouth closed, cleaning the body as needed, placing pads to absorb any draining fluids, elevating the head slightly to prevent pooling of blood that causes discoloration, and putting on a clean gown or shroud.
Then transport.
Then, following facility policy, the body is usually identified with tags and prepared for transport, perhaps to the morgue, or maybe kept in the room for a period if the family wishes and policy allows.
After the death, we enter the realm of bereavement and grief. It's not straightforward, is it?
Not at all. Grief is complex. It can be ambivalent. Sometimes there's relief that the suffering is over, mixed right in with profound sadness and loss. Initial shock often gives way to periods of depression, maybe anger, lots of crying. It's all normal.
Kübler-Ross's stages are well known. Denial, anger, bargaining, depression, acceptance. How useful are they in practice?
They provide a framework, but the most important thing the chapter stresses is that the process is rarely linear. People don't just march through stage 1 to stage 5.
They bounce around.
Exactly. They might cycle through stages, revisit anger, long after they seem to reach acceptance. It's unpredictable. Our role as caregivers isn't to push them through stages.
What is our role then?
To support their emotional expression, encourage them to talk, to cry, to share memories, listen without judgment, and please avoid cliches or minimizing their loss, saying things like they're in a better place or it's time to move on is usually not helpful.
Recommend support.
Definitely. Suggesting support groups or professional grief counseling can be very helpful, especially if the grief seems unusually prolonged or complicated. And don't forget our colleagues.
Meaning?
Ancillary staff, nursing assistants, aides. They often form very close bonds, especially in long-term care. They grieve too, and they might face family anger or frustration. They need support and guidance from the nursing team as well. #TagOutra.
So wrapping this all up, if there's one core lesson from this deep dive into geriatric end-of-life care, what would you say it is?
I think it's the shift in focus. It moves completely away from curing towards achieving the best possible quality of life that remains and facilitating what we called a good death, defined by the patient.
Which takes that proactive planning we talked about.
Yes, proactive planning, really holistic assessment, physical, emotional, spiritual, cultural, and just a deep, unwavering respect for the patient's and family's values.
And the nurse's role in all this is, well, it's huge. More than just giving meds.
Oh, much more. You're a coordinator, an advocate. Pushing for those earlier hospice referrals when appropriate, making sure pain management is relentless, because as we said, that fear of pain is just so significant for people facing the end of life.
You know, the text implicitly raises a tough ethical tension for the caregiver, doesn't it? Balancing maybe a family's desire to keep fighting, keep prolonging life, against a patient's clearly stated wish for comfort, for dignity.
That's often the hardest part, is where your own values, your own understanding of the goals of care really get tested, which brings us back to that self-reflection.
Right. So for you, the listener, the learner, maybe the final thought is to really consider your own views. Where do you stand on things like artificial hydration at the very end, on palliative sedation? Knowing your own ethical baseline is probably a first step to providing truly objective, patient-centered care.
Well said. That value clarification isn't just an academic exercise. It's essential preparation for supporting others through maybe the most profound journey they'll take.
Thank you so much for joining us for this deep dive. We genuinely hope this discussion helps empower you to be an even more effective, compassionate, and holistic caregiver